Okay, inshallah, we'll start our first case. Dr. Amr will start. You are the doctor in charge in neurology clinic. Mr. Smith has been suffering from Parkinson's disease. His symptoms were poorly controlled despite being compliant to his medication. He started to complain from on-off phenomena as well. Your consultant was supposed to meet him to discuss the option of deep brain stimulation, but for an urgent issue, he couldn't attend. The consultant asked you to meet Mr. Smith and discuss with him the issue of deep brain stimulation. Your task: discuss deep brain stimulation with Mr. Smith as an option of treatment and manage his concerns. دكتور عمرو افتح المايك.
انا فاتح المايك.
لما تبقى ريدي تمام.
تمام.
مم.
Okay, I'm ready.
Okay, start.
Okay, good morning. I'm Dr. Amr Ashraf, one of the medical doctor here. I would like to confirm you are Mr. Smith.
Yes.
Okay, I am here to address any of your concern. So feel please to talk, please, if you are ready to talk.
It's okay.
Okay, I would like to know what do you know about your condition so far, Mr. Smith?
Has been suffering from Parkinson's disease since 10 years now. And on treatment for it, I received many medication. Despite this, my symptoms was worsening with frequent fall. And actually, I think no treatment is making me better. So the consultant told me that he has another option. That's why I'm here today.
Well, you have a very good idea about your condition, Mr. Smith, and that's why I am here to talk to you today. As you said, you have been suffering from Parkinson, and I'm really sorry for that. I assume that you have been taking some medication and you have already suffered from its side effect, like it's an sometimes you feel your symptoms are more progressive when you are taking your medication. So our consultant today decided that he want to change your medication and to give you an additional one. So are you ready to talk about this?
Yes, please.
Well, the consultant in charge offered to give you something called deep brain stimulation. Don't mind the name, okay? It is something that it is a form of electrical treatment. We give your brain an electric impulse, so it cause some sort of stimulation in your brain and decrease the effect of your Parkinson disease.
Uh, so, would you tell me more about this, please?
This form of treatment is used when usual medication of Parkinson's disease has failed, like you have been taking this medication and you have experienced some of its side effect, and we can't control your symptoms or medication anymore. So this treatment, you will be put on a device, and this device will introduce some sort of electricity, electric current to your brain. Its dose is measured in order not to harm you. Okay. The idea of the device is to stop the active area in your brain that is responsible for the development of Parkinson's disease.
Oh, you mean it is a kind of surgery or a device that I have to use? I don't understand the point.
Okay, no, it is not a surgery, and also it is not a device you use. It is like one session or a two-session trial. This electrical impulse is done under supervision of the medical team. It is a procedure, and before the procedure, we are going to run some investigation in order to make sure you are ready to receive this form of treatment. And during the procedure, you will be put on the device, and there will be some electrodes that are connected to your brain, and this electrode will deliver the electrical current to your brain in a measured dose. And if you ever experience any pain or unrelief, then you can ask the doctor to stop. Okay, and after this procedure, you will be put on a place on a recovery room, so we can take care of any complication that ever developed during this. During this treatment, there is no much complication could occur, but some people suffer from they suffer from headache. Some people also suffer from pain from the electrical current, and that's the procedure in brief. So, are
Mm.
you okay with that?
And just I want to understand more. How long does it last? And for how many time I'm going to repeat this session?
Well, the session it lasts for about 15 to 30 minutes, okay? And regarding the number of session, I'm sorry, I don't know the number exactly. The consultant hasn't decided the number of session yet, but it is decided according to your response to the treatment.
And is it totally safe?
I cannot say it is 100% safe. Any procedure has its complication, so although there is some sort of complication, but I can guarantee that it is done by expert medical personnel. And if any of complication ever developed, we are ready to deal with it. As I told you, the most common complication is like headache and some pain. We can give you some painkillers for the pain, and if you ever develop headache, and also we can have some medication for that.
Mm. Doctor, and shall I stop the medical treatment on this condition? I mean, if I do this session, shall I stop medical treatment, the pills?
Well, I appreciate your concern, Mr. Smith. Unfortunately, we will still need to take the medication. This is an additional treatment for you.
Mm.
This device is used to add benefit to your drug. It doesn't work alone, but it work alongside the medication we are giving you. That's why I'm so sorry for that, but you will still be on your medication.
Yes, I see. Um, so what is the benefit of this procedure if I'm going to maintain the medication?
Well, the benefit of this procedure, you will suffer less from the side effect of the medication. I assume that you have developed some complication of the pills you are taking for Parkinson, as your symptoms progress more and more frequently. Am I right?
Hmm. Yes.
Okay, well, then this device or this procedure, we are hoping that this will decrease the progressiveness of your symptoms, and we will not need to increase the dose of your medication. This is the aim of this device.
Mm. Okay, doctor. I think I need some more time to think about this. Um, and also I
Uh,
need to read more about this device.
Feel free to take your time to think. I can give you provide you with some brochure about the procedure, and if you want, I can give you a site and a video to the procedure in brief, if you want to.
Mm, okay. 2 minutes remaining.
Okay, so what is your concern, Mr. Smith?
I'm really concerned why my consultant didn't attend the meeting because he told me that he's going to attend this meeting today. So why he is not here if he's going to discuss a new treatment like this?
Well, so sorry for that. He has an appointment. It was an urgent one, so he asked me to be here for you. And if you want to meet him, to talk to him in person, I think I can arrange a meeting for you with him. And I am sure he would be considerate of this.
Hmm. Okay. Is this modality of treatment going to improve my symptom or just decrease the
We are
load of medication?
well. We are hoping that it will decrease your symptom, but we are not expecting that. It will just decrease the dose of your medication and keep your condition stable.
Hmm. Okay, doctor.
Okay. Anything else you want to know or any other concern?
Just I want to read more about this procedure and then give you my decision.
Okay, feel free to read about this, and I will give you some videos for this procedure, and I will give you a brochure to read about this procedure as you want.
Okay, doctor. Thank you.
Thank you.
Thank you. Time finished. طيب هو احنا confused between deep brain stimulation and electroconvulsive therapy صح؟
هو مش الاتنين واحد؟
لا. electroconvulsive therapy أو ال ECT is used في ال major psychiatric problems زي schizophrenia مثلا psychosis but ال deep brain stimulation used في ال uncontrolled tremors whether benign essential tremor Parkinson tremors ف it is totally different. ال deep brain stimulation um, um, like pacemaker of the brain. Okay, so you
Uh-huh.
start your conversation by greeting. أو before we start, let's see what the examiner expecting from you. Um, First of all, في أي communication scenario, introducing proper introduction of yourself and make a good rapport with the patient, confirming the patient identity and set the aim of the meeting is very important. Here, there is important statement mentioned in the scenario that the consultant was supposed to run this meeting, but for urgent issue, whatever the issue, he is not here today and you are going to run the meeting instead of him. In such
Okay.
condition, you have to start your conversation by apologizing about the absence of the consultant and asking for permission to run the conversation instead of him. This is ethical issue important because the patient is expecting to meet the consultant, not you. It is important to ask the patient current understanding of the condition and the expectation of the meeting. Uh, Also important to use clear, simple words, avoid jargon, check the understanding throughout, and if the patient's following you and that you are clearly explaining everything to him and he's following every step before shifting to the next step. Empathetic patient-centered approach is very important. This in general for any communication scenario. In this scenario, the clinical content of this scenario include explanation, deep brain stimulation. Simply and accurately, what is deep brain stimulation? Highlight the indication, give balanced benefit and limit benefit or risks of the procedure, explain the procedure itself, cover the risks, key risks here, bleeding causing stroke, possibility of infection والهاردware أو wire complication. Note that deep brain stimulation is not a cure for the condition, but just improve the symptoms, and mention programming and follow-up. Decision making, explore expectation والfears priority of the patient, offer alternative if the patient refuse, what is the other alternative that you can use, support the patient autonomy, provide safety netting, والmost important here if the patient accept to ask about consent because you are talking about procedure. So if you are going to summarize this scenario, good morning, hello, I'm doctor, and mention your family name. I'm here today to let me confirm that you are Mr. Smith. Mr. Smith, we are here today to discuss about your medical condition and a new treatment option suggested, not decided by the consultant. First, let me apologize for the absence of my consultant because he has an urgent issue. He couldn't attend this meeting. So if you allow me to run the meeting instead of him, it will be okay. Is it okay with you? Then you proceed to exploring how much you know about the condition. Let me first ask you how much you know about your medical problem and what do you expect from our meeting today. Actually, you have been, like you mentioned, suffering from Parkinson for a long time and not responding to medical treatment. And as I can see from your medical record, you have started to have a complication of the treatment itself. So I'm here today to discuss a new option of treatment suggested by our consultant, which is called deep brain stimulation. Do you have any idea about this? Have you ever heard about a surgical treatment for your condition? In this procedure or surgery or kind of treatment, it is used mainly in uncontrolled tremors like Parkinson or other forms of tremors when tablets are no longer controlling the symptoms. So it involves placing very thin electrodes into special parts of the brain, controlling the movement, and these electrodes are connected to a battery that is placed under your collarbone. الكولربون اللي هي الكلافيكل via tiny wires. This is fixed in place and this device send via this battery electrical impulses or pulses that help movement circle to work more smoothly. To be honest, this will significantly improve the tremors, the stiffness, the slowness, and the on-off fluctuation that you have. But it does not cure the disease and does not prevent its progression, but will improve the symptom to a good extent. This means that you are not going to stop the medication totally, but we can decrease the dose. Like it do like brain pacing, we can control this abnormal movement or shakiness of the hand and this stiffness by adjusting this device. During this period of controlling this movement activity, we can have some problem like balance problem, like memory or speech problem, which is temporary. Like any procedure, it can have some complications. So we talked about the good things. Now we talk about the complication. Any device, if you are going to insert any device, you are subjected to certain complication like bleeding, which can cause stroke, introduction of bugs, injury to nearby part, slippage of the device. The battery itself, it can be rechargeable or non-rechargeable. If non-rechargeable, then it will last for around 5 years and need to be replaced after that. If it is rechargeable, take around 10 to 15 years to be replaced. The wires are placed in place or in the brain with under scan or under image guidance. So this minimize the expected complication, and our team is specialized in this procedure. They are skilled and do it with minimal complication, if any. The device will be adjusted in a clinical setting, in outpatient setting. So this will control the movement disorder in a better way, which will improve your quality of life. And as I told you, it is adjustable and reversible. Um, as I mentioned to you, the risks of this device. So what do you think? Do you think about trying this modality of treatment? If he agree, I'll tell him that you have to sign a consent. All details are written. You have to read it carefully and sign the consent before proceeding, and feel free to ask about anything which is not clear. If you you are hesitant in proceeding, I assure you that it is your right totally to decide or take your decision, and we are going to support your decision. But I can offer you some um, like YouTube links or videos about this procedure. You can read more about this. I can provide you with some links or pamphlets about the procedure you can read more about, and we can discuss it later. And if you don't mind, I can arrange another meeting with my consultant. This in the case he refused to discuss more about this issue with you. So, would you tell me how does it sound so far? Any question, any other questions do you want to ask me about? Um, then, would you tell me how much you got from our conversation to check the understanding and he got the issue in a good way? Okay. Any question?
Yes, doctor.
Yes, doctors, please.
Doctor, there's any special side effect or complication for brain stem stimulation? Apart from the injury and infection, there's any specific side effect or complication?
Good question. First, the complication, the most common, bleeding, the infection, will injury to nearby part which can cause fits. During adjustment of the movement, there can be some problem in memory and speech, which is reversible. Any device, any tube that you are going to introduce, whether pacemaker, chest tube, a PCN, deep brain stimulation, is subjected to slippage or misplacement. Both of them can happen. But added to this, if it is tube, not wire, like in our case, if tube, like intercostal tube or PCN, also blockage can occur or obstruction. Okay, these are the common and the most important and most serious as well complication that you have to talk about. And surprisingly, the issue of apologizing about the absence of the consultant is very, very, very important in the evaluation of your performance in such scenario. Sometimes you have scenario which is not you are not familiar with. In such condition, you have to follow the basics. I mean, you can just touch the issue from the safe points. You have to say why you need this procedure and what if not. Simply, if you have any fine idea about the procedure itself, you have to talk about the complication, like any procedure, injury, bleeding, bugs, like I told you, slippage if it is wire, or obstruction if it is tube. And you talk about the importance of follow-up, okay, and consent. And if you are asked any question which you are not sure about, just tell him that you don't have this piece of information right now, and you are going to recheck and tell him. If you are asked a question which is not, you don't have a clear answer for it, okay, or you don't have the information. Admit uncertainty if you don't know the answer. Okay. Any other question? طيب, let's move to the next.
Is it done under general anesthesia, Dr. Mona, or not?
Yes, it is done under. It is like called
Sedation?
stereotactic surgery. It is stereotactic surgery. It is like laser, making a very tiny hole and introduce this device, and it is rather local anesthesia with sedation, not general anesthesia.
Okay.
And by the way, if you want to mention anesthetic complication like anaphylaxis or a sensitivity, you can mention it. Okay, but if you want to add this, but it is not essential. Any other question?
Doctor, please, if I give some wrong information, is it fatal in the assessment or?
I don't know who I'm talking to. Before you talk, just introduce yourself, please. If you don't know, don't say. خلاص. خلينا make an agreement in paces, in whatever station in paces. If you don't know, don't tell. I don't have this piece of information right now, because if you give wrong information, you are going to be penalized for this. خلاص, you are not allowed to give wrong information. But if you are not sure, just admit that you are not certain about this issue, and you are going to recheck and come back with the answer for you. خلاص. So admit uncertainty, be honest is very important. Don't try to expect or try to formulate an answer which is not, you are not sure about.
شكرا.
كتير. تمام. طيب, any other question?
Excuse me, Dr. Mona, but if I am not certain and I'm going to say that I am not certain about the procedure and I don't know, like I have, like what I have
Okay.
did, I don't
Perfect.
know what is deep brain stimulation is okay, and I thought it was something else. I think I like that I feel the station, but if I don't know what is deep stimulation is exactly, and I am just touching the issue from the safe points, like the indication of the procedure and the complication, the expected complication, and the main concern of the patient is that he want to know what is the procedure and how it's done. So how can I deal with it? I think I will lose
Yes.
the mark of managing patient concern like that.
طيب, let's mention two things. First, your performance was perfect for ECT, but it is not the scenario. And this was a clear example of what is going to happen in the exam. If you go in the wrong track, the surrogate will go with you. He will not correct you. خلاص? This is one issue. The other issue, if you are not sure, again, don't say something that you are not sure of. But يعني خليك حسن التصرف. يعني if you mention that it is a treatment for, it is a kind of treatment used for uncontrolled tremors done by surgical treatment. Like any surgery, it can have some complication like bleeding, injury to nearby part, introduction of bugs. These are all general information. I don't have the details, but you have to know, because it is one of the scenarios which came in cases previously. So you have to know these details, not more than what I mentioned in the explanation of the case previously. But if you mention that this surgical procedure, and he started to ask you about the details of surgery, you mentioned to him, if you agree to do this surgery, I will arrange a meeting with the surgical team. They are more expert about the details of this surgery, and they are going to tell you everything that you want to know. And you have total right in this, because you don't have to know the details of the surgery, but you have to know the deep brain stimulation, like pacing of the brain. Like the pacemaker, like you are talking about the pacemaker. If you are going to talk about pacemaker of the heart, you are going to mention the electrodes connected to wires, and these wires connected to battery. Right. There are something else that I forgot to mention, and this is very important. Any patient with device or prosthesis, you have to mention that you are going to give him like a medical report that he is using a device because there is a metal, there is a wire. Then when he passes through the electric gates of the airport, of malls or whatever, it will give alarm. So you have to give him like documentation that he is putting a device. Also to avoid magnetic field like MRI. And to mention to his doctor if he need to do this kind of imaging that he is using a device. Um, Now all the metal devices and the wires are plated to avoid this issue, but you have to mention this if and it is good to mention. Again, this doesn't require specialized knowledge in this issue. So if you just touched this kind of surgery done for controlling the abnormal movement and the stiffness, and it entails introduction of certain device to control the movement and the stiffness. And like any procedure can have some complication. You mentioned the common complication. You are going to pass clearly, but don't forget to apologize for the absence of the consultant. You got my point? طب if you are asked about a specific thing that you don't know the answer, you have to admit that you are not sure about the answer, um, or you cannot recall this piece of information right now. I'm going to recheck and tell you the answer. But if you mention to him, I don't know about deep brain stimulation, no, you lost the scenario. You got my point?
Yes,
Mm,
thank you, doctor.
thank you. طيب, any other question? طيب, shall we proceed? مين هياخد النكست كيس؟ دكتور عبد الرحمن؟
Yes دكتور معاك.
Mr. Ahmed Sultan, 23 years old, complaining of leg swelling. Please take a history and examine him as a puppy.
Okay دكتور منى, shall we start?
Yes.
Okay. Hello,
Hello.
I'm Dr. Abdurrahman. I'm one of the medical doctor here in the clinic. I assume that you are Mr. Ahmed Sultan, 23 years old.
Yes.
Hello, Mr. Ahmed. I'm here with you today to discuss with you your medical condition. So, can you give me a hint about your complaint?
I have been complaining of leg swelling. It started now since around 3 months. Since the start is progressively worsening.
Okay, 3 months. Is it
Mhm.
to one leg or both legs?
Both legs.
Okay. Is it sudden onset or it's gradual?
Over the last 3 months.
Okay. And it's progressive, right?
Yes, it is worsening this time.
Okay. Is it painful?
No.
Okay. Did you notice anything that might be increase these swelling?
Like sitting or standing for a long time increase this swelling, and when I lie down at night, it decreased by the morning.
Okay. Can you tell me the swelling where to what level exactly to your leg? Is it to the
It
knee, above the
started,
knee?
yes, it started around my ankle, then extend to just below my knee.
Just below your knee.
Mm,
Okay. If there is any rashes in your on it, rashes,
no,
swelling, or hotness.
no,
Okay. Okay, Mr. Ahmed. Um, okay. If there is any fatigue,
no,
yeah. Okay. Any bumps or lumps in your body you have noticed
no,
recently? Okay.
no,
Any night fever?
no,
Okay. Any coughing up blood or chest pain?
no. Uh, Coughing up of blood? No, just once maybe. I have
Once.
one attack of coughing up of blood. Yes.
When it exactly?
Maybe 3 or 4 weeks ago. I cannot recall. It was just once.
Okay. Can you tell me more about that? Did you have a medical consult about this before?
No,
Okay. If there is any chest pain when you cough up blood?
no,
Okay. Any racing of your heart? Any fever?
no,
Any symptoms? Other symptoms you have noticed while you are coughing blood in this time? At this time?
no,
Okay. Okay. Any joint pain?
no.
Okay. Any recent change of your weight?
I believe that I put on weight.
Okay, can you tell me how much?
I'm not sure, but I feel this. There is swelling all over my body.
Okay. So you put on weight, but you don't know how much.
No,
Okay. If there is any abdominal swelling,
no, tummy swelling. No,
tummy swelling. Okay. Any skin rashes or rashes on sun exposed area?
no,
Okay. Any mouth sores or sores in your private area?
no,
Okay. Any a change of the size of your ring or shoe?
no,
Okay. Any unusual cold or hot intolerance?
no,
Any change of your bowel habits?
no.
Okay. Um uh, any can I ask you a private question? Are you married?
Yes,
Okay. Do you have a children?
no.
Okay. Any change in your intimate relationship? Do you have a morning erection?
Yes,
Yes. There is nothing abnormal.
no.
Okay. Any disease pills?
Sometimes.
Okay. When you're standing up or you're
Yes, when
okay.
I stand from sitting or lying down.
Yes. Okay. Any hair loss?
No,
Okay. Um any history of blood transfusion or chilling needle or tattooing?
no,
Any unprotected casual relationships?
No,
Okay, any family history of blood clot, or do you have a previous blood clot?
no,
Okay. Any change in amount of urine or the color of the urine?
no.
Any frothy urine?
Yes, it's frothy.
Frothy since when?
Around 3 months, possibly.
3 months.
Hmm.
Okay. Any buffness of your eye
In the morning.
in the morning? Okay. Any difficult in combing your hair or doing standing up from sitting position?
No.
No.
Hmm.
Okay. Any fever?
No,
Okay. Um, okay. Any history of recent travel?
no,
Any long-standing disease?
no,
Okay. Any family history of gland problem?
no,
Any family history of similar condition?
no,
Okay. Do you drink alcohol?
no,
Okay. Do you smoke?
no.
Okay. What about your mood? Is it right or
It's okay, no problem. Just
okay?
anxious about the cause of my
Okay.
symptoms.
Can you give me a list of your medication?
Just inhaler, blue and brown inhalers, and this is all.
Okay. Why do you take inhalers?
For chest symptoms.
Okay. Wheezy chest?
Yes, I have easy chest.
Okay. Okay. Since when?
Oh, long time. Long
Okay.
time, doctor. Years back.
Any nasal crusting?
No.
Okay. Can I examine my patient?
Mm-hmm.
Okay. I will look first at uh, lower limb. I will
There is
see
edema?
is it betting or not betting, and
Yes.
up to what level. Also, I will see any signs of DVT or any signs of infection like hotness, redness, maybe cellulitis. Uh, Also, I will make a general examination, including looking for the hand, uh, uh, looking for any signs of chronic disease or pulmonary edema or tubular contraction. I will check the pulse, looking for it regular. I would like to perform blood pressure, sitting and standing.
Mm.
I will look for the face, and for the eye, for any redness or pallor or jones. Also the mouth. I will also make a full abdominal examination, including ballotment of the kidney. Uh, that's all.
Mm.
بس
There is lower limb edema, blood pressure 120 over 80 and 90 over 60, and abdomen is free,
abdomen is
and
free
nothing
and
in general. Hmm?
okay, and I
Apart
will
from
examine
clubbing. Hmm?
apart from clubbing.
Mm.
Okay, and the chest examination.
With the chest and the risk repetitions.
Fine or coarse crepitations.
Course repetitions. 2 minutes remaining.
Okay, what's your concern?
I'm concerned about the cause of my symptoms and if this is a curable condition.
Okay, I appreciate your concern. Actually, you have both uh, symptoms of chest, and you have you told me that you have a frothy urine, which make a broad differential diagnosis for this. Um maybe a systemic disease cause these symptoms. We shall have some blood test and urine analysis and some tests for your urine, and we will and then we will recheck with you, the result.
So,
We'll inform you the
do
result.
you have any expectation, I mean?
I think it's a systemic disease which affect your chest and your kidneys both. Maybe some kind of inflammation of your vessels, or so we will check the labs first, and we will inform you what we
Okay,
will do again.
thank you. Yes.
Okay.
What's your diagnosis?
In regarding the wheezy chest and the kidney affection and his young age, maybe granulomatosis with polyangiitis, maybe vasculitis, uh, uh, also maybe Churg-Strauss syndrome.
With each diagnosis, please tell me what is with and what is against your diagnosis.
Okay, Churg-Strauss syndrome, it can affect, it make wheezy chest, and it can affect the kidney, make a frothy urine. Also, granulomatosis with polyangiitis can make these symptoms also. Maybe cystic fibrosis can affect also the chest, signs of wheezy chest and coarse crepitations.
Again, sorry. الو
ايوه يا دكتور.
كمل يا دكتور. cystic fibrosis.
Yes.
What is with and what is against?
With his young age and the signs of coarse crepitations and wheezes, which mean maybe suppurative lung disease, or and the against is the kidney affection.
What is the cause of his kidney affection here if it is cystic fibrosis?
Um, it's not come to my mind actually right now.
And why he has these spells?
It's maybe likely an autonomic neuropathy, or
From what?
um, I don't know right now.
Okay. How are you going to investigate him? Okay.
Okay. I will basically I would like for CBC, inflammatory markers, urine dipstick, renal function test. Also, I would do an CT chest and pulmonary function test. But also, I would like
What do you call pulmonary function?
maybe obstructive pattern.
What do you mean?
It means that if EV1 over ratio of if EV1 over with a forced vital capacity is below 0.7.
What else investigations?
Also, I would like to perform an autoimmune panel,
Hmm?
autoimmune screening, and sputum culture and asphalt bacilli.
Hmm? Okay, what about the treatment?
The treatment according to the etiology.
Hmm?
Also, if according to the etiology, first we should control his frothy urine by know its underlying according to its etiology.
Hmm.
ال
By
ال- مم،
okay. Hmm. Okay, thank you.
ماشي.
طيب anyone has any comment?
Dr. Mona, is it positive has a pulmonary infection and renal affection? Sorry, I
It's
missed it.
not clear يا دكتورة. Please identify yourself first then دكتورة عزة.
Yes.
اتفضلي.
He has a pulmonary affection and he has a renal affection.
Mm-hmm.
Okay. And the leg swelling, you said below the knee.
Mm-hmm.
So it's like a wegener, and he has a complication like DVT.
Mm-hmm. طيب. Okay, thank you. Any other comment? This is how to approach leg swelling. I'm not sure if the screen is shared or not. Okay.
واضحة يا دكتور منى.
Okay. Leg swelling, the onset of course of duration, is it all the time or comes and goes? The extent of the swelling, if you proceed, does it leave mark? And this differentiate between the pitting edema or the fluid and hard edema like lymphedema or mixed edema. Any redness, hotness, pain, or difficulty to walk, they are the signs of inflammations. Redness, hotness, pain, and loss of function or inability to walk. Then we have to differentiate between two causes of leg swelling. Is it one leg, unilateral leg swelling? Will differential diagnosis here will be trauma, it will be painful, or compartmental syndrome. Cellulitis, it will be red hot and painful. DVT, again, it will be painful, and you have to ask about the causes of the DVT, complication association, rupture Becker cyst, and there will be underlying chronic joint problem and swelling behind the knee before the onset of this leg swelling. But here the situation is different. We are talking about bilateral leg swelling or anasarca. Bilateral leg swelling, we have 5 differential diagnoses. If you have a swelling in the body anywhere, you have to ask about swelling elsewhere, namely puffy eyelid in the morning, frothy urine or change in urine volume or color. This for renal causes. Number 2, ask about swelling in lips and tongue for angioedema. And this is a characteristic feature of angioedema. Angioedema come in the exam by different scenarios. Can come with leg swelling, can come with abdominal pain, facial swelling, breathing problem or noisy breathing. And the clue is the bilateral leg swelling and to ask about swelling in the lips and tongue. You have to ask about tummy swelling, ascites. If there is tummy swelling, it is hepatic edema because usually for the localizing factor of portal hypertension, the tummy swelling precede the leg swelling. The screen is shared, right?
Yes, doctor.
Okay. We have also to ask about breathlessness. Breathlessness lying flat, breathlessness awake you from sleep for cardiac edema, and ask about diarrhea for nutritional edema. These are the 5 differential diagnoses of bilateral leg swelling. So if you have renal cause, you have to ask about always, if you have a renal problem, whatever the complaint is, remember the chest. You have to ask about all chest symptoms, include cough, phlegm, and if you have a phlegm, you have to ask about the amount, color, odor, relation to posture. This will be the diagnosis. In this case, you will diagnose bronchiectasis from the analysis of the phlegm. If you have any kidney problem, remember the chest. If you have any chest problem, remember the kidney. You ask about cough, phlegm, and analyze the phlegm. Cut of blood, wheezy chest, breathlessness awake you from your sleep, breathlessness that comes on lying flat. You also ask about upper respiratory tract symptoms, including sinus pain, nasal stiffness, or crustation. Ask about the cardiac symptoms like racing heart, chest pain. So, if you have a kidney problem, you have to ask about the chest symptoms in details. Here, from the analysis, you have excessive amount of sputum that is colored, odored, and related to posture. These diagnose bronchiectasis. And the relation between bronchiectasis and the kidney, bronchiectasis is one of the chronic infection causing a long-standing infection, causing amyloidosis in the kidney, causing a nephrotic syndrome. And this is the cause of leg swelling. And this amyloidosis explain autonomic neuropathy. Autonomic neuropathy can present by many features. You have to recall them, please. Amyloidosis can occur with long-standing infection or inflammation. Remember, in rheumatology, rheumatoid arthritis and ankylosing spondylitis. In chest, you have TB and bronchiectasis as long-standing infection. In endocrinology, diabetes can cause amyloidosis. And also, you have other causes like FMF and Crohn's disease also can be complicated by amyloidosis. So here you have a case of bronchiectasis complicated by renal amyloidosis causing the leg swelling. The amyloidosis can present itself by renal symptom, can present by carpal tunnel. So asking about the hand pain, that is electric shock-like, increase at night, decrease by shaking of the hand. This is spells on a standing or changing posture for autonomic neuropathy, a posture hypotension. Impotence can be a cause. Such a case of bronchiectasis can present with impotence. A case of rheumatoid arthritis presenting with impotence. A case of ankylosing. Why? Because of amyloidosis and autonomic neuropathy. Diarrhea alternating with constipation. All these are autonomic features, can be associated with autonomic neuropathy as a complication of amyloidosis. The story didn't finish here. We have to check out the cause of the amyloidosis. So you have to ask about kids, not problem in intimate relationship. Kids, because of immotile syndrome or Cartagner syndrome, they are infertile. The Cartagner or immotile syndrome does not affect the potency, but affect the fertility. You have to ask about kids. You have to ask about by name, childhood bugs like measles or whooping cough by name. You have to ask about risk factor for HIV. You have to ask about tuberculosis because it is also a risk factor for bronchiectasis. And you have to ask about very important thing, which is recurrent admission or infection because of hypogammaglobulinemia. And it is a scenario coming in the exam by different way, can come with diarrhea, can come with bronchiectasis, can come with leg swelling like this case, and come back to be hypogammaglobulinemia. So if we just try to recall the cause of bronchiectasis, from childhood, remember there is congenital causes like immotile syndrome, and here there will be bronchiectasis, there will be infertility. Cartagner syndrome, there will be situs inversus with right-sided apex. So in the examination, you have to look for the apex side. Also, primary cystic fibrosis will be associated with bronchiectasis and diarrhea, recurrent diarrhea. And primary hypogammaglobulinemia usually present with recurrent infections young age. Then when the child grew up, he is subjected to foreign body aspiration. It will be localized bronchiectasis. If he grew up more, he is subjected to childhood exanthems like measles and whooping cough. With age, he is subjected to tuberculosis, HIV, and in elderly cancer. These are the causes of bronchiectasis. You have to recall them. Bronchiectasis is one of the very important topics which can appear in places in the clinical station, in the communication, and in the lung case. The chest or communication or lung case. Regarding your concern, your problem is related to a long-standing problem in your chest affecting your kidney, which cause leakage of protein in your urine, causing this leg swelling and the generalized body swelling. We have to confirm the diagnosis by run some urine and blood test and check the chest scan, and then discuss with you further management. Your examination should be directed to the general examination, looking for clubbing, ask for blood pressure, sitting, standing, check the proximal myopathy, pallor jaundice, mouse, and lower limb edema. This is called general examination. Auscultate the chest for obstructive lung disease signs and crepitations of bronchiectasis. Bronchiectasis is one of the obstructive lung disease causes. Also, check the site of the apex. If it is right or left-sided apex from Cartagena syndrome, ask to do bimanual examination of the kidney and listen to the base of the lung. This is your examination. If you have symptoms like carpal tunnel, hand pain as a complication of the amyloidosis, you have to check for it as well. During the discussion with the examiner, I'll tell him like this: these gentlemen presenting with bilateral leg swelling, yes, evidence of nephrotic syndrome, most probably secondary bronchiectasis, which is caused by whether hypogammaglobulinemia, Cartagena syndrome, whatever, according to the case, the scenario that you have. Or, like I mentioned, you have to ask about measles and whooping cough came in the exam previously. The case like this exactly, but with measles as a cause of bronchiectasis. Investigation, he come with the leg swelling. So I will start with the kidney. I'll check for urine albumin creatinine ratio, urine analysis, ultrasound of the kidney, check for the CT, high resolution CT scan of the chest, looking for either signet ring appearance in early bronchiectasis or later on honeycombing. Check for the diagnosis of amyloidosis by checking buccal mucosal biopsy or abdominal fat or rectal snip biopsy. Also, check for carpal tunnel if it is present by nerve conduction study. And the treatment will be directed to the cause. Here, as amyloidosis complicating bronchiectasis, we have to remove the bronchiectatic focus if it is localized, either to loop or to lung, because it starts to have distant complication. Surgery is not a treatment for bronchiectasis. Bronchiectasis is treated medically by bronchodilators, antibiotics during exacerbation, and mucolytics. This is the most important treatment. But if it is complicated by spreading infection to the rest of the lung, by distant septic emboli, by amyloidosis, should be surgically removed. Unless if it involves the lung bilaterally, unfortunately, in such condition, there is no option for surgery, but you have to proceed to whether a symptomatic treatment or lung transplantation, bilateral lung transplantation, or heart lung transplantation. Clear? Any question?
دكتور بالنسبة للهايبوجاما جلوبينيميا هيجيب diarrhea و chest symptom؟
Hypogammaglobulinemia can come with any infection. Can come with diarrhea, can come with bronchiectasis, can come with septic arthritis, meningitis, any infection at unusual sites. And the most important, that starts since early childhood.
Okay, how can differentiation between cystic fibrosis
and
hypogammaglobulinemia and cystic fibrosis?
Hypogammaglobulinemia, recurrent infection at different sites. Like I told you, septic arthritis, meningitis, any infection. Like in cystic fibrosis, come with diarrhea and bronchiectasis only.
Okay, thank you.
Thank you. Any other question?
Hello, I have a question, Dr. Lamis. May
Dr.
I
Lam.
ask?
Yes.
Yeah, so in the differential diagnosis, if we say the ANCA positive vasculitis
Good.
as one of the as one of the pulmonary renal syndromes, but then we can argue like against that the patient has an a
Yes.
dizziness,
Features of amyloidosis.
yes, which is
Yes.
not explained by vasculitis, but
But let me
it's an acceptable diagnosis.
let me ask you before answering this question, what are the renopulmonary and pulmonary renal syndromes?
Right. So these are the vasculitic syndrome that affect both the kidney and the lungs. The anti-GBM. Also,
I just, Dr. Lamis, please just nominate the cause and give me the characteristic feature of each, the diagnostic
okay.
feature.
So it could be the ANCA positive vasculitis as the Shirk-Strauss. So this will be the triad of having chest symptoms along with the renal symptoms as well. It could be Wegener granulomatosis or the GPA. This like having symptoms like nasal crusting, chest symptoms, and also renal symptoms as well. It could also be what else? Sorry.
Let's categorize them into 3 groups. The pulmonary renal association can be ANCA-associated vasculitis and non-ANCA-associated vasculitis and pulmonary renal syndrome without vasculitis. ANCA-associated vasculitis, we have 4 syndrome. Good pasture syndrome, it presents by bleeding from the lung, hemoptysis, and hematuria, whether microscopic or frank hematuria. So it should be bleeding. Good pasture, the antibody against the basement membrane. It destroys the basement membrane, cause bleeding from the lung and bleeding from the kidney. Number 2, microscopic polyangiitis. Microscopic polyangiitis come also with hemoptysis and nephritis, active nephritis, means there is hematuria, whether microscopic or gross hematuria, with skin rash, maybe joint pain. Number 3, we have Wegener's granulomatosis, and this is obsolete name. It is polyangiitis with granulomatosis. It is associated with nephritis, active nephritis, plus nephritis, not nephrotic. Nephritis mean oliguria, hematuria, and hypertension, impaired kidney function. This is nephritis. And all the 3 syndromes that I mentioned include nephritis. Upper respiratory tract symptoms, including nasal stuffness, crustation, sinus symptoms, and lower respiratory tract symptoms like hemoptysis, like cough, like other symptoms of the chest. And when you do the scan, you find migratory cavitation. The 4th syndrome, which is ANCA-associated vasculitis, Shirk-Strauss. Shirk-Strauss cause wheezy chest and hypertension, renovascular hypertension. It does not cause nephritis. So it is totally different issue and cannot be put in this category. خلاص, though all these syndromes cause nephritis, not nephrotic. خلاص, together with upper and lower chest symptoms, plus upper chest symptoms can be present in Wegener's, and also MPA can be associated with upper chest symptoms. So these are 4 vasculitis, and you have to know clearly the diagnostic feature of each of them. So you cannot put at all Shirk-Strauss in such case because it does not affect the kidney itself. It affects the vessel, the renal vasculature. Number 2, non-ANCA-associated vasculitis. Non-ANCA-associated vasculitis, which can affect the lung and kidney, like lupus, like any medium-sized vasculitis. can affect the lung and the kidney. Number 3, non-vasculitic pulmonary renal symptoms like TB can affect the chest and cause amyloidosis in the kidney, like lymphoma. Lymphoma can cause chest symptoms together with whether causing stones from hyperuricemia or hypercalcemia, causing kidney symptoms, or causing paraneoplastic nephrotic syndrome, membranous nephropathy. Malignancy of the lung can be associated with paraneoplastic nephrotic syndrome, membranous nephropathy, and malignancy of the kidney can metastasize to the lung. Condition like sarcoidosis can affect the lung and affect the kidney. HIV can affect the lung and the kidney. These are all non-vasculitic causes of pulmonary renal affection. Renal failure of whatever cause can cause volume overload and cause chest symptoms. This is renopulmonary. So the relation between the kidney and lung not only related to the ANCA vasculitis, it is extensive. Condition like bronchiectasis, like TB, can affect the kidney by amyloidosis, malignancy, lymphoma, vasculitis, all types of vasculitis, not the ANCA-associated, no, I mean like lupus, rheumatoid arthritis can affect the lung, causing pulmonary hypertension, causing lung fibrosis, causing bronchiolitis obliterans, pulmonary nodule, Kaplan syndrome, costochondritis, and can affect the kidney, causing amyloidosis. Ankylosing spondylitis can affect the lung and affect the kidney. Ankylosing cause apical fibrosis and cause amyloidosis, affecting the heart, and affect the kidney by amyloidosis. So you have a strong relation between the lung and the kidney. For that, like I mentioned here, see, any kidney problem, remember that lung. You have to ask about all chest symptoms, not only for renal ANCA-associated vasculitis, but for the renopulmonary and pulmonary renal association. Clear?
Thank you so much, Dr. Amina.
Thank you. Any other question? طيب دكتور وفاء, we have now the chest case. Chest
I am sorry, Dr. Mona. I just first time to listen. I don't know to.
لا لا دي clinical. Just read كده the finding is short case, a clinical case.
Anyone can share.
طيب اوكي ما فيش مشكلة. حد تاني من الجماعة ممكن يشير؟
Yes, Doctor. حد تاني for case.
Anyone interested to share the next case?
Yes, Doctor, I can.
Yes, please. دكتورة.
Rasha.
Welcome, Dr. Rasha. Okay, this is a short case. This chest case. Just read the finding, and I will give you the auscultation finding and the start discussion.
Okay.
This gentleman, please read it in loud voice.
This gentleman lie breathlessness in the bed with respiratory rate 24. He look under belt with evidence of obstructive lung disease in form of dimension, concretosternal notch distance, and limitation chest expansion overall, hyperresonance percussion, and encourage on the liver dullness, vesicular breathing with a prolonged expiration, and listen to the crepitation, widespread bronchi, auscultation.
Just give me a second, I'll give you a auscultatory finding.
Doctor, you want me give to differential diagnosis?
Yes, we are going just to listen to this, then
Yes.
you start.
There's no voice.
Okay, give me a second.
Yes, there's no voice.
برضو طيب okay, I'll share it on the group. Tell me the diagnosis according to the finding.
Okay, regarding this gentleman
There is a crepitation, coarse crepitations.
presented with coarse crepitation.
This crepitation was coarse crepitations, yes.
Is not changed with the cough or changed with the cough?
No, not changed.
Not changed with cough.
Slightly changed.
Is what?
Slightly changed.
Slightly changed. Okay. Regarding this gentleman, obstructive lung disease plus bronchiectasis, obstructive lung disease for differential diagnosis.
Okay, what's your differential?
The first, my differential diagnosis, COPD. The second differential diagnosis may be bronchiectasis. The third may be asthma.
Yes, how are you going to investigate him?
Apart from the basic investigation, I want to do full blood count and CBC, LFT, renal function test, serum electrolyte. I want to do chest X-ray, ABG, pulmonary ABG, pulmonary function test for reversibility test, and DELICO, and also total lung volume and residual volume, ABG and high resolution and CT.
What do you expect to find in the high resolution CT?
Regarding, yes, if the patient, if a bronchiectasis, I saw the signet ring appearance. If the patient's COPD, I want to do the CT or not high resolution to if there's any bolus, if there's any bolus. Bully, if there's any bully. And also I want to do ABG and chest X-ray pulmonary function test, echo and ECG.
What do you expect in pulmonary function?
Pulmonary function test, obstructive lung disease, forced expiratory volume to the 1 second, and over the forced expiratory volume less than 70. And theirs is not reversibility, is negative with the reversibility test.
Okay, what about the treatment?
Regarding to the treatment, pharmacological and non-pharmacological, patient education and counseling, patient vaccination, advice to the patient to the stop and to the smoke, pulmonary rehabilitation program, and social, psychological, financial support. Regarding the patient obstructive lung COPD, a patient started into the short-acting salbutamol and plus short-acting anticholinergic. If the patient forced expiratory volume is 50, is needed to start it into the long-term beta agonist plus the inhaled steroid or long-term antimuscarinic. If less than 30, you started the long-acting beta agonist and plus inhaler steroid and plus long-acting antimuscarinic. Maybe patient needing to this for medical treatment, and there's maybe other treatment like long-term oxygen therapy or non-invasive or the patient surgical treatment.
Okay, thank you. This is a typical case of bronchiectasis. In bronchiectasis, clinically, you find the patient has clubbing. This is the general examination. Usually, the patient is breathless, frequently coughing, expectorating excessive amount of sputum. So you find beside the bed either a sputum cup, small cup with a sputum. You have to inspect the amount and color, if you can, the odor, or you find a lot of tissues beside the bed. And this is characteristic feature in bronchiectatic patient. You either find the patient wasted, and this signify the underlying cause of this bronchiectasis, because it is like one of the protein losing disease causing wasting in the muscles of the face especially, and possibly the hands, may indicate the underlying cause, like we mentioned, TB, malignancy. So it is important to mention the body build of the patient. Frequently coughing, expectorating excessive amount of sputum. You find signs of obstructive lung disease, because bronchiectasis is one of the causes of obstructive lung disease, like increased anterosteric diameter of the chest, limited chest expansion, hyperresonant percussion note, encroachment on the hepatic dullness, vesicular breathing with prolonged expiration, bronchi, and the characteristic crepitation of bronchiectasis. The characteristic crepitation of bronchiectasis, if you ask the patient to cough, bronchitis crepitation, which is the secretions that happen to most of us, clear completely with cough. If the crepitation persists, and this is the most important, not the change with cough. If the crepitation persists after coughing, you have to listen to the crepitation. If it is of the same intensity from its beginning to its end, it is bronchiectasis. If it increases in intensity from the beginning, it is low at the beginning, then increase by the end of inspiration, like you open the cuff of sphygmomanometer, the crepitation is leathery like or velcro like or have crescendo pattern. This is crepitation of fibrosis. These are the persistent crepitation, either bronchiectasis and fibrosis, and you differentiate between them by the intensity and of the crepitation throughout its length. If it is the same throughout and very coarse, this is for bronchiectasis. Another tip that you should know, in a patient with bronchiectasis, if you put your hand over the side of the crepitation and ask him to take a deep breath, you feel the crepitation under your hand. It is palpable crepitation because there is secretions. So if you are confused, you have to do this. And from the beginning of examination, if you find the cough of the patient is dry, this excludes bronchiectasis. Dry cough excludes bronchiectasis, but the reverse is not true, because fibrosis may be associated with superadded infection or underlying COPD. So bronchiectasis is one of the causes of obstructive lung disease, but you have to find the crepitation characteristic of bronchiectasis. You cannot put bronchiectasis in the differential of other causes of obstructive lung disease. Obstructive lung disease can be caused by asthma, by chronic obstructive airway disease, by bronchiectasis, or occupational asthma. Bronchiectasis has a characteristic feature that does not put it into differential with other causes of obstructive lung disease. But if I ask you about the differential of bronchiectasis, you have to mention the causes that I mentioned in the previous case, like congenital causes, cystic fibrosis, immotile cilia syndrome, Cartagena syndrome, hypogammaglobulinemia, foreign body aspiration, TB, recurrent infection, aspergillosis, malignancy, and HIV. These are the causes or differential diagnosis of bronchiectasis. So bronchiectasis is a separate diagnosis. You cannot put it in differential with asthma or obstructive lung disease. It is one of the causes of obstructive lung disease, but the differential diagnosis is the causes of bronchiectasis. Investigation of bronchiectasis, basic CBC, SAR, CRP, electrolyte, sputum culture sensitivity, acid fast bacilli, pulmonary function test and in bronchiectasis you expect to find obstructive pattern in which forced expiratory volume in 1 second over forced vital capacity less than 70 or 0.7. High resolution CT, and in high resolution CT you expect to find either signature appearance due to thickened wall of the bronchi, causing this appearance in the early stage, signature appearance, or later on you find the honeycombing. X-ray changes in bronchiectasis does not appear till late, and you find the classical train line or tram lines, which is parallel thickened lines representing dilated thickened bronchial walls. Bronchoscopy should be done if the bronchiectasis is localized to one loop or one lung, because it can be related to obstruction, like foreign body or endobronchial lesion like cancer. So you have to do bronchoscopy if it is localized bronchiectasis. In the management, you consider non-pharmacological, include education and counseling about the condition, stop smoking, vaccination against Haemophilus pneumococcal seasonal influenza, social, psychological, nutritional support, and the most important is pulmonary rehabilitation program and postural drainage. This is the most important. Give the patient mucolytic, very important in bronchiectasis. Give antibiotic according to culture and sensitivity, and bronchodilator if there is evidence of obstructive lung disease signs. If there is localized bronchiectasis, you can remove the obstruction. In case of bronchiectasis is complicated by spreading infection to nearby lung part causing fibrosis, or distant septic emboli, or amyloidosis, in such condition you have to proceed to surgical option, which is lobectomy or pneumonectomy if it is localized to one loop or one lung. But if it is bilaterally, you cannot remove both lungs, and in such condition you are just allowed for medical treatment till there is option of transplantation. By this, we finished our meeting tonight. Thank you for your attendance, and if you have any question.
Yes, Dr. This is Dr. Mahjoub. Firstly, thank you for this great and informative sessions. And just I have one clarification regarding your differential diagnosis regarding the bronchiectasis. When they ask me what is the differential diagnosis, because the COPD sometimes with superimposed infection, it will be looks like bronchiectasis. And I will say bronchiectasis with its causes are the differential diagnosis, or I can mention bronchiectasis plus COPD.
Perfect. Thank you for your question, Dr. Mahmoud. COPD is the most important issue that you have to diagnose in the lung, because it can be complicated by any chest problem. Yani COPD can be complicated by fibrosis because of recurrent infection, and tuberculosis because of lowering of the local immunity of the lung. COPD can be complicated by bronchiectatic changes from recurrent infection. COPD can be complicated by lung cancer. So you have COPD with bronchial breathing, area of bronchial breathing, for example. So COPD can be a compensatory hyperinflation, not COPD, but a compensatory obstructive lung disease, compensatory hyperinflation for lobectomy or pneumonectomy. So if you have obstructive lung disease with area of bronchiectatic change, you mentioned COPD complicated by local area of it is small area of bronchiectatic change. But if you have clear bronchiectasis involving a part of the lung or lung completely or bilateral with clubbing, you have to mention this bronchiectasis. You got my point? COPD can be associated with bronchiectatic changes, and usually this will be super added bronchiectatic changes on top of fibrosis. يعني COPD يحصل recurrent infection, fibrosis يحصل tractional bronchiectasis، تعمل bronchiectatic changes، فبتبقى very localized area. and the patient smoker and you find the star stain مثلا for example, and you find or you find the classical blue bloater for example, or pink feather, so it is a case of COPD complicated by bronchiectatic change. But if you find patient with unilateral or bilateral bronchiectasis أو for example complete loop bronchiectasis مثلا apical loop or whatever, لا, you have to mention case bronchiectasis, and the differential diagnosis will not be COPD because bronchiectasis is one of the cause of obstructive lung disease. يعني you can have signs of obstructive lung disease in bronchiectasis and the patient is not smoker and not COPD. You got the point?
Yes, thank you.
Thank you. Any other question?
Doctora, I have one question regarding this patient have the sign of hyperinflated chest. Is also can I say bronchiectasis because decrease the distance and also hyperinflated chest?
The same like Dr. Mahmoud just asked. You have bronchiectasis, one of the causes of obstructive lung disease.
Yes,
like I mentioned in the beginning.
Yes.
We have to differentiate between two terminology: obstructive lung disease and COPD or COAD. Obstructive lung disease means signs of hyperinflation can be present in asthma, in COPD or COAD, which is related to smoking, chronic heavy smoking, or can be related to bronchiectasis or occupational asthma. Okay. The difference between all these, the presence of bronchiectasis crepitation, the crepitation of bronchiectasis. If the signs of obstructive lung disease are present, and there is crepitation which completely cleared by cough, you can mention chronic obstructive airway disease, which is related obstructive lung disease caused by chronic smoking or alpha-1 antitrypsin deficiency according to the cause. But if you find this crepitation does not disappear with coughing, and it is of very coarse character, and the patient has clubbing, so you mention it is obstructive lung disease due to bronchiectasis. It is the cause of obstructive lung disease, bronchiectasis itself. You got it?
Yes, you mean but can differentiation by crepitation, yes?
Yes, the presence of bronchiectatic crepitation, crepitation of bronchiectasis. خلاص, you cannot say COPD, خلاص, it is bronchiectasis. Unless if it is very localized, small area, which we call it bronchiectatic change, and the majority is obstructive lung disease signs, you can say COPD complicated by bronchiectatic area of bronchiectatic change. But if you have bronchiectasis and the crepitation occupying major part of the lung or good part of the lung, so you have to mention bronchiectasis.
Yes, thank you.
Thank you. Any other question? Thank you for your attendance. وإن شاء الله meet you next time. شكرا يا دكاترة. دكتور علي, هستأذن حضرتك ترفع لنا التسجيل على التليجرام بقى. شكرا, تصبح على خير.